good to see everybody having an interest in telehealth and what's going on with it. What I've done in this presentation is sort of raised 5 questions I think we all need to be in a position that we could answer if we engage in telehealth delivery of therapy via telehealth. And so what I've done is taken each of those questions and attempted to give them some kind of an answer. As I move through the presentation, if you have some questions that get queued up for you, feel free to use the chat feature and let us know what it is that's on your mind. In terms of how I'm thinking about it, the way I'm thinking about this presentation is to back up from a consumer calling the 491 board or writing the 491 board and saying, I wasn't handled well by my therapist who delivered telemental health therapy. What were you placed in that defensive position of saying, well, I thought I did really, really good work. What do you need to be able to say to anybody who says, well, what do you mean you did good work? I think you need to be able to answer these 5 questions. 1, were you aware that there are some ethical standards regulating your behavior? 2, did you get any training? And if so, what kind of training did you get? 3, did you think through clinical issues as you work with this particular client? And I'm thinking more specifically there, the fact that you're a systemic family therapist. And then finally, this whole idea of best practices. It's a trend nationally in anything that we're looking at. And I think anybody listening to you defend yourself would want to know, do you know what they are? Have you thought anything about them? And have you done any work in those kinds of an area? So that's the way that I've organized this. As we move through it, feel free to use the chat to raise some questions that get provided there. I'll stop every once in a while and just check to see, does that sort of ring true to you? Do you have anything else you'd like to know, or anything else that kind of comes to your mind?
So Richard, quick, before you do that, this is Richard Long, who is on the west coast of Florida. And if I correctly remember this, sir, you were part of the group that wrote the law in Georgia for telemental health. Is that not correct?
That's correct.
And you are also the chair of, I think, the committee for AAMFT at the national level on this topic.
That's right. And in addition to that, I'm working on the CEO's work group on developing mental health app standards for mental health, marriage and family therapy providers.
You're going to have to tell us what that means, because I'm not sure what that means. So when you get to it, you'll tell us what that means.
Okay. There is a PowerPoint that kind of it supported this presentation, and I'm thinking, I'm not quite sure how it'll get to you, but we can talk about that as we move through the presentation. Let's begin by talking a little bit about ethics and regulatory issues. The first place to start is essentially Standard 3 in the AAMFT Code of Ethics. Talks about the idea of professional competency and integrity. It's 3.0, and it's the maintenance of competency. And the idea there is, hey, if something's new going on in the field, the discipline, whether that's a new model, a new theory, or whether in this case, a delivery system, the idea is that you receive some kind of education, some kind of training, perhaps some supervision on whatever that might be. So that's the first place to start. Second place is this idea of regulatory standards. Are you aware of them? Have you checked them out, thought anything about them? And what are you doing in terms of understanding what the regulations are? When it comes to what's newly defined, Standard 6 talks about technology-assisted professional services, which covers a wide range of things going on from a technological point of view. Annalyn, we were just talking about the idea of mental health apps. There's an app for mood disorders. There's an app for anxiety. There's an app for, Irma, you mentioned before we got started, suicide prevention. There's an app for that. And essentially, whenever we're in this position of taking a look at technologically assisted, first thing that comes to mind is the business of consent, informed consent. Are we in a position where we've said to our clients, here are the risks, here are the benefits of whatever this technology is? What do we know? What do we not know? And that's rather specific when you think about it. You know, what do we know in terms of couples work? What do we know in terms of family work? And do we share that with the clients in our informed consent? The issues of confidentiality, always tricky with respect to making sure that, particularly when it comes to these airways, that they feel safe. They feel like we're using, you know, current technology, that we're doing our best, and that we communicate to them, hey, here's the protections I've got on my end. You know, let's make sure you kind of understand those. And if you're not comfortable with those, you know, let's talk about that. The other issue that's really important, you know, in those ethical standards is documentation. Do you have adequate notes about what it is that's been going on in session? And where are those notes? How are those notes stored? Who has access to them? Who doesn't? How does all that work? And then finally, the use of training. And I'm going to get to training in just a minute. One of the things that's fascinating on the regulatory area is the Florida Telehealth law. In theory, that was to happen July 1. It's House Bill 23. One of the things about that bill is that, from my understanding, it has not been signed, and it's pretty likely that it's not going to get signed. But I think what's important about it is what's being said, because I think it's a precursor to where are we going to go in terms of regulations next. The first thing that it says is, guess what? Telehealth services are valid. Okay, it's affirming, you know, what most of us already have been thinking and believing, but that's the direction things are going. Nobody is saying no to telehealth. They're saying, yes, it's valid. Now, I think for us as practitioners, we've got to be able to show our clients valid to do what? And that's another kind of issue. The second thing that's talked about in that law is new practice standards. Practice standards for documentation, practice standards for patient record keeping. My guess is that that's going to set for the 491 board some movement that's going to have to happen. I haven't seen a set of standards for patient evaluation. I haven't seen a set of standards for patient record keeping from the 491 board. If this law gets passed eventually, it seems to me to make sense that something's going to happen in both those areas. There is a super excellent app that I'll have to share with you in a few minutes. Oh, it's called My Outcomes 2.0. And you might want to jot that down. I'll come back to it later. But it's based on Duncan and Miller's outcome rating, session rating scale. And I think all of us would you know, really be in really good shape if we take a look at that, see whether it makes any sense for us for adoption, and we can think a little bit about that. So the other provision for that telehealth law had to do with the registration process for out-of-state professionals. Now, the fascinating thing for that is that that's kind of a sideways portability law. Okay, that's where that's going. And it's fascinating that they're using the word registration instead of the word portability. And they're introducing this idea that that's where we're going to go. And actually, when you think about portability, it looks to me like the way it's going to get there is through telehealth. And you know, I may be wrong about that, but I think that's where it's going to go.
I think it's interesting that it invites people outside of Florida to treat Florida population, but it doesn't do a thing for Florida clinicians being able to practice outside of Florida. We have to
Right.
get other states to do
That's right.
something like that to
That's
give
right.
us flexibility.
That's right. And, you know, and it's fascinating because, you know, Florida becomes the state that basically introduces a fairly innovative, you know, way of practicing. So who knows where that's going to go. The last provision of this bill basically was what's called, what's the reimbursement provision. And that's where the bill got hung up. And it got hung up in the medical community because it didn't quite do what the medical community expected to have done. So despite the fact that the bill failed, or at least it's not been signed this week, I think we need to look for coming down the pike, the idea that something's going to happen on this patient evaluation business and something's going to happen on record keeping, and we need to be prepared for, you know, whatever that might be. With that being said, okay, never mind. I was just looking at the comment to Annalyn.
Yeah,
Okay.
let me just say real quickly that the current Florida statutes, or actually not even the statute just says you have to document. The rule is what makes clear that you have to have name, start and end date, time, people there, blah, 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 right?
Right.
So that's as close as we have to anything that tells us what we have to document. But it does, and it says it has to be secure because we have HIPAA, but it doesn't say anything about, you know, what has to be in an assessment or any of those kinds of things. It's still pretty wide open as to whether you even have to diagnose or what your treatment plan looks like in private practice. Though many people have either their insurance, you know, the insurance people that they work with, or Medicare, Medicaid, that will dictate some of that. But for private practitioners, it's still the Wild West as far as you can pretty much do anything you like.
Right. Let me move to the idea of training. When we're talking about training, and I put together a chart, and hopefully we'll be able to take a look at it at some point. The question is, who are the leading providers nationally? What sort of content are they providing? What sort of format are they using? What's the pricing look like? And then sort of websites, how do I find out about these people? Before I get into talking about these in detail, let me give you where I think this is going to come out in terms of expectation. I spoke with Susan Gillespie, who's on the 491 board, about 6-9 months ago. And I said, when you get into your, you know, work on this issue, what's guiding you? Her answer was the Association of Marital and Family Therapy Regulatory Board Teletherapy Guideline. Okay. Most of us don't even know what that board is. I was on the board for a couple of years. For the most part, the last time most of you probably would remember it is when you took the test. This is the group that creates the MFT test. Essentially, that's the deal. They created a document in 2016 in which they outlined how they see telemental health happening. For them, the answer is 15 hours of some kind of training initially. Okay. And then they said they wanted 5 hours of CEs every year thereafter. Okay. So the idea would be if in fact you're providing, delivering therapy via Telemental Health, the AAMFT group would say, get 15 hours of training, and then every year, make sure 5 of your hours would be, you know, focused on telehealth kinds of issues. Okay.
Hopefully they don't mean yearly. Hopefully they mean per renewal period.
Per renewal period. Thank you for clarifying that. Okay, so what are the groups? Well, they're the Telebehavioral Institute. They're the Person-Centered Technology Group. They're the Zur Institute. It's the Telehealth Certification Institute. and AAMFT. Now, what's fascinating about that is one, who could get you 15 hours of CEs?
Oh, the institute that's training.
Okay, so the deal would be the Telebehavioral Health Institute would meet AAMFT-RB's standards. The Person-Centered Technology Group would meet that standard. The Zero Institute group out of the West Coast will not meet the 15-hour standard. The Telehealth Certification Institute would meet the standard. And guess what? Drum roll, please. AAMFT's, how do you pronounce it? TINCO? They're continuing.
Tenneco? Yeah,
Yeah,
Tenneco.
TINCO does not meet the standard. They have 2.5 CEs, period. Okay. When I checked earlier this morning. Now, maybe they added a 15-hour, but that's kind of what it is that's there. So we're left with saying, all right, I need to check out these groups if I want my 15 hours. What are they going to teach me? Well, they're going to go through some basic concepts. They're going to look at models. They're going to look at technology. They're going to look at law. They're going to look at best practice kind of things. They're going to look at, as Anna Lynn mentioned, they're going to look at security issues. They're going to look at confidentiality issues. They're going to look at emergency planning. They're going to look at, the difference between phone use and text and video conferencing and all those kind of things. So that's the content. Format is online for every one of those. So if you want to take one of those, you can do it in your PJs, which is a really good thing that's there. Now, in terms of pricing, I need some math major to figure this out for me. It runs basically from $40, which is, that 2.5 Cs, up to, listen to this, $1,496. I see a few jaws open.
That's $100 per credit.
Okay. All right. Thank you.
Which is, of course, ridiculous. And of course, Richard, when Florida demands that we do 15 hours, there will be many of us who will create that for us. That
exactly.
we will do it in-house.
That's right. Okay. So it's a wide range in terms of fees. And if you want, hey, Dr. Oliver, how are you? Welcome. The thing that you want to do, and we'll work out how you get this information, is basically Google each one and begin to do a comparison and take a look at price per CE per vendor and begin to explore which ones do you think make the most sense for you. I'm not going to get into, telling you. I've experienced the content from 2 of them, and I have some, personal opinions about it, but I'm not going to get into that. But I do want you to know that they exist, and it's a really good thing for you to begin to explore each of those.
But at this time, it is not required by our state statutes or rule to get this.
That's correct.
So if you do get it, you presumably will be ahead of the curve and presumably will meet the standard for whenever it does come into existence. But AAMFT-RB and those organizations do not dictate our statutes. They might be a consultant to, but do not dictate them. So we do not yet have that training standard. That's
correct. Now, the next place I want to go is clinical issues. And that's kind of a fun thing for us to get into as therapists. And when I think of that in about 3 different ways. One is making sure client readiness to do telehealth, talking a little bit about personality types, and then this idea of doing systemic therapy via telemental health. So the first issue is this question about client readiness. We talked earlier about assessment. One of the things you want to do prior to working with the client is figure out where they are in this whole business of using technology. Are they people that blog? Do they do discussion posts? Do they go into chat rooms? Are they set up on social media? Do they do Instagram? et cetera, et cetera, et cetera. Are they kind of early adopters somewhere in the middle, which I think most of us are, or are they people that, you know, aren't there at all? And I think that's really important, because if you get a great deal of feedback that says to you, they're late adopters, and then this next question is their comfort level. You know, they talk about confidentiality a lot, and they worry about safety issues. And I would say to you, if you're getting that kind of feedback, you really might want to back off a little bit and say, you know what, I think we need to talk face-to-face kind of stuff, you know, before we move into this business of telemental health. So I think that's the first thing. There are, you know, if you Google it, there are 2 or 3 client readiness forms you can find, you know, out there. And I would encourage you to basically, you know, sort of think through and make sure, one, you've checked for client readiness, and 2, put in a case note somewhere that says, I checked, and, you know, I asked some questions, and here were the answers, and I'm comfortable moving forward, or we worked it out and said we're going to do face-to-face. So I think that's the first thing that's there. The second has to do with personality types. And I think this is kind of fun to think about a little bit. If you think of something like you have a client who has a narcissistic personality disorder, okay? What are you doing when you put the camera on them? Huh? What do you think is kind of happening here? Huh? Okay, just kind of, you know, wondering about that. You have a client who's paranoid, and your child knocks on the door because they want you to check their homework. Or in my case, the dog walks in. What's a paranoid client doing while you're working with them? You know, or your spouse or significant other calls and says, is dinner ready, or whatever else might happen. Okay. So when we think about working with clients, I think these personality, you know, disorder things are kind of, you know, good for us to back up a little bit. Let's go with obsessive compulsive. Okay, the obsessive compulsive would look at my books on my bookshelf and say, they're not in alphabetical order. How can you be doing this work and not have your books lined up? Okay, need to be thinking about that. Let's go with histrionic. I'm not gonna do that anymore. What happens when you get a histrionic client? And think about this for a minute. When you have a histrionic client in your office, and your office is outside your home, you know, you had to maybe work out with some colleagues and say, hey, I've got somebody who's going to be a little loud. They might be screaming. I need you to get ready for this. But when you're in your home, you know, think about the dog, think about your children, think about the people in your home, and what happens when they hear screaming coming through your speaker. What's that like for them? Have you prepared your, you know, the folks that you're living with for that kind of person coming through? So I just say to you, it's kind of fun to think, and it's interesting. I got a flyer today from somebody who's basically doing a webinar on personality disorders. This is a PESI one, and they're going to be in town. I guess they're going to be in Orlando, Tampa, and Hialeah doing. You know, talking about,
but not necessarily telemental health with those
no,
particular. Okay.
No, but it just sort of says to you, you know, people are looking at personality disorders and beginning to think about doing that. For us, I think we have to, you know, think about what's going on for us as marriage and family therapists. What are the principles we're working with when it comes to this telemental health issue? You know, essentially, when you think about it, the idea of relationship and the idea of interaction, thinking a little bit about context, thinking about patterns, purposefulness. We're able to think on multidimensional kinds of levels and work in a counterintuitive kind of way sometimes. I think the idea here on the clinical side is to keep in mind how in sync is our work in telemental health or telebehavioral health with our own theoretical orientation. And is it compatible, and does it work or not work? Let me give you some examples. Those of you who like, you know, structural family therapy, can you do structural family therapy in telemental health? Can you say, who's more worried about this, mom or dad? You can do that. Those of you who are into Bowenian, extended family therapy systems, I'm not sure what you meant when you said that Sally sounds like your mom when she raises her voice. Bowenian? Sure, can you do that? Makes really good sense. For those of you who have some sort of a behavioral oriented kind of therapy that you work from, we have two rules here we're going to be working from. One is I want you to begin your sentences using I messages. And the second one is every time you start raising questions, I want you to turn them into statements. Can you do that in telemental health? Sure you can. And then finally, well, two more. Let's go with those of you who like solution focus. Can you do scaling questions using telemental health? 0 to 1, how you doing? Sure, you can do that. And then for those of you who've been trained recently with Sue Johnson's emotionally focused therapy, can you do an enactment in telemental health? Joe, I want you to say to Sally what it feels like when she says you have spinach in your teeth. And all I would say to you is, it seems to me that it's, good therapy is good therapy, whether it's done in person or done online. And yes, you have to kind of think about cameras and lighting and et cetera, et cetera, et cetera. But if you think about it, the models and theory and therapy and techniques we use in MFT seems to me to make really good sense in terms of doing the work that we need to do. The other issue I want to focus on before we move into questions has to do with best practices. One of the first best practices, I think, is, we need to make sure we're doing an assessment and need to recognize that there are not sitting out there a ton of, I guess, for want of a better term, valid, reliable instruments when it comes to doing telemental health and saying, this one's been tested in a telemental health setting and therefore makes really good sense. One of the ones that I'm most attracted to, and I mentioned it earlier, is the Duncan and Miller's My Outcomes 2.0, because it's one of those session by session, big picture kind of look at the work. How are you doing right now? Do you feel respected? Do you feel listened to? The kinds of issues that are there. It's not tied to a specific model or specific theory, but I think anybody saying, do you know where the client stands session by session? Have you, looked at them and how they're different this session than the previous session? That seems to be a really good out. Okay, you pulled it up. Cool.
I just wanted to share, Richard, that when I was at Nova in the clinic, I was part of the original team that started to ask those questions before the end of the session when we were doing the family work. So that's really interesting, the client outcome measures. Right. They were just great questions to ask, and then you incorporated the feedback into the next session with the client. Yeah.
I was a clinical director for an agency in Georgia, and we used it for the entire staff. And I always found it fascinating, particularly when we were working with interns, this idea of feeling respected. And the therapist, the client would ding him on feeling respected, and the student would go, I thought I was being very respectful. And I'd go, well, did you talk to your client about that? Okay, well, I expect you to go back in and talk about where did that, idea come from? And they'd go, I didn't know what it did. And it was like, oh, I cut them off every time they wanted to tell their story, or I didn't give them eye contact, or I let him talk more than her talk, whatever it is, it is. And it, that instrument, cues up all that stuff, and it's very, very helpful. Even I'm just talking about using it with students, but it was also helpful with more seasoned interns. Another practice, best practice, I think, is this idea of making sure you know who you're talking to. And I threw away I don't have my driver's license in front of me, but the simple, way to do that, is to basically flip up a driver's license at the beginning of a session, so that you're able to put in your notes, confirmation of who this person was. Particularly for those of you who are, taking a look at these online counseling therapy services. I think the idea of making sure you don't get trapped by a ghost client that may or may not exist or may not come back on you later. A simple, at the beginning, okay, now where are you? You're in such and such a city. What's your address? Such and such an address. And then, can I see a driver's license or something to let me know that the person that I'm talking to, is the person that reveals themselves. That's one of those things that most of us are not particularly cautious enough about, and probably need, to go, oh, wow, I didn't even think that people could do that. But the consequences of failing to do that, can come back on us. I think another practice that I would want to recommend to you is the idea that you start with your ongoing face-to-face in-person clients. Somebody that you've been working with, say 8 to 10 sessions, you almost have them at maintenance, and you move from this face-to-face in-person to telehealth. I think that's a really good way for us to get confident in this work, and a way to maintain, a level of success for the client. Because in that scenario, you don't have trust issues. When the dog walks in, they're not freaking out because you've been talked about the dog before, or you had a photo of the dog sitting in your office, or whatever it was that was there. So I would strongly recommend, this idea of thinking through in terms of client selection, rather than go with something cold for you and for the client, go with something that's warm, something that feels trusting and supportive for them and for you, rather than something out of the blue in which somebody goes, boy, I really need treatment and I really want help and I'm desperate. And we get caught in something that, we would go, wait a minute, maybe I ought not be practicing at that kind of level. Anna Lynn mentioned earlier the whole business of encryption and HIPAA and business associate platforms and all that kind of thing. And I think everybody, has seen enough literature about that to kind of recognize, that you need to be working with those kinds of hardware, software, VC, Doxy, Telehealth 360. There are, 3 or 4 of them out there. Go ahead.
What do you think of platforms like Simple Practice? And I think there's counseling with a K dot, is it OI or IO? But there's a number of these platforms that you can pay for that, and Simple Practice, I think, is actually advertised by AAMFT.
Yeah, it is. Yeah. I haven't done a pilot test on Simple Practice. I have, in fact, neither one of the ones that you've identified. So I'm not quite sure.
And there are lots more that I have seen,
yeah,
or been told about that I can't remember right now. But if there's 3, there's a dozen or
That's
more.
right.
Yeah.
Yeah. And I think, one of the questions always, in selecting one of those has to do with this business of HIPAA compliant and encryption, and what are they doing and how are they ensuring, and what's their work and what's their experience with that. In a sense, there's almost, has a client complained about their particular software? What sort of complaints have come through? Have there been breaches? How have they handled the breaches? All those are kind of questions that I think, when you're looking at Simple Practice or anybody else, that you want to raise them. And it can be, if we have enough time, we can sort of brainstorm whatever else, we might want to do before we move into those. The other point I want to make when it comes to best practices, and it's one of those things that really threw me off the first time I heard it, and it has to do with crisis intervention planning with respect to telemental health clients. And let me sort of tell you what it is I'm thinking about there. It is the idea, and I guess, Irma, you were mentioning it prior to us getting going. It's the suicidal client who basically, and I don't want to do it to you right now, but it's the client that clicks buy. I've decided to do this and I'm out of here, click. Okay, and for you as a therapist, it's really super important that you've thought through that possibility and done something about it. The something about it is when you are establishing and setting up a relationship, you go, give me 3 people I can contact, okay? Your best friend, your aunt, your uncle, your brother, your sister, your whatever it is, and give me their cell phone, okay? The other has to do with sheriff or police department. Give me somebody, you know, within 5 miles of you who I could contact if something terrible would happen. If your house, you know, you don't have to get into the detail with it. If your house caught on fire, tell me where the nearest fire department is, or give me the number for an emergency, you know, service of some kind or whatever it is.
And so these are all things that one could put in a biopsychosocial
That's right.
form.
Absolutely.
That
That's
we,
right.
I don't know how much of that people would gather. None of the police and fire and all that kind of stuff would we collect in a land-based in-person environment.
Absolutely.
We might want the contacts.
That's
Yeah, we
right.
might want the emergency contacts that we might get. But then how many of us really want to look at particularly if they're a cash paying client, how many of us look for driver's license?
Right,
But
exactly.
those who do insurance, they would take a copy of the driver's license.
That's right.
So this,
Yeah.
and that's stuff that could be scanned to you ahead of time,
Absolutely.
right? Leverage all the technology, and then this would all be a part of your documentation.
That's right.
In the event of a crisis. So
That's right.
I love it, Richard. I love it.
Okay, and even the idea of, you know, not to get too cautious or paranoid about it, but if, for example, they gave you a public, you know, like a sheriff's department, pick up the phone and dial it.
Mm-hmm.
Find out whether or not that's a real sheriff's department. And if you get the real sheriff's department, cool. But if you don't get a real sheriff's department, you have to kind of say to yourself, what's going on here? And it could be, okay, they just transposed numbers, or you wrote the numbers down, or the document, you know, was blurry when you got it and there was a scanned copy and you couldn't read the scanned copy or whatever. But I would certainly want to come back to my client and say, you know, we talked about this and I don't know what happened here, but can you kind of clarify it for me? Have a discussion about it. And they go, oh yeah, we just transposed numbers. And you go, cool, that's fine. And then try it out. Go ahead, Annalyn, you wanted to.
Well, I was going to say, how much of some of this extra caution that you're talking about, or really, it's probably the caution any of us would take, but we have to think about it kind of differently in the video and distance environment. Because in a way, I mean, why do video if they live 5 miles away from your office, right? So why would, so the only really good reason to do video is because they're too far away to be able to usefully come in.
That's right.
So what I'm thinking is that if you have multiple people, like right now I do work with a couple and I have them both on camera, I'm a whole lot less concerned about this crisis stuff because I've got other people.
That's right.
So I'm thinking if you've got one person, if you're doing an individual session, then your need for all of this preparation goes up.
That's right.
Or if you have multiple family members, but maybe they're in different parts of the country. Right. Maybe you're talking about a parent and child is far, far away at college or something.
Right.
So then again, I would think that the need to prepare would go back up.
Absolutely. Well, and if you think of something like, for example, when we're all working with domestic violence cases in our office, we take a lot more precaution with those clients. well, think about that in a telehealth kind of context,
Yeah.
In which he's being very, coy and very warm and friendly. And you're sitting there going, I think, well, how you would manage that in your office and how you would manage that in telehealth is something you've got to think about. And to Anna Lynn's point, get some, basically have a record, have tracking in which you've raised those issues and you've taken, the steps you need to take to do that. Go ahead.
And I'm wondering, with the new law, with the new rule that came into effect of applying a tariff off in Florida,
yes,
with intimate partner violence or any type of domestic violence, we do now have a duty to warn and a duty to protect.
That's right.
Because
absolutely. And if you have that sheriff's number,
right,
it's pretty easy to do for somebody who's 60 miles away or 100
right.
miles away or whatever.
Another thing you mentioned was having the client show the driver's license on the screen, and I love that idea. And then at that moment, asking them, "Is this your current address?"
That's right.
Because then, if you have to do a 911,
that's right,
have the address.
You got it.
Well, and I'm thinking I don't even want it flashed at me. I want you to scan it and send it to me.
Okay.
I want
right.
Just scan the thing. Yeah.
Yeah, because
what's it called? My little scanner, and do it on your iPhone and give it to me.
Yeah, take a picture on your iPhone and text it to me.
Right.
Yeah,
absolutely.
Let's leverage all the technology.
You got it. The other thing I want to talk about is this informed consent business a little bit, and recognize we were talking earlier about models and theory, okay, and this idea of the work that we're doing and what do we know about telehealth. I mean, for example, you're going to do CBT and you're going to do that on depression. There are about a half a dozen research articles basically saying telemental health is a way to go for treating, it makes very good sense. It's as good as in person. Well, make sure you're letting your clients know that, in the informed, consent documents. When you think of a half a dozen or sort of, presenting problems that clients come up with, there basically is a body of research that kind of says, you know what? We know that telemental health works with that. With a half a dozen populations and a half a dozen presenting problems, and put that in your informed consent so that they're able to, kind of recognize you've done your homework. You know that telemental health works. You're not just kind of like making this up. You've got a set of, research articles that basically back this up. And I think that's really important for them to do. The other thing that I want to talk about at this point is this business of social media. And I don't know, for the most part, I think this is probably something I've experienced more with students than with professionals, but it is this idea of separating our social media, making sure that there's a distinction between what we do professionally and what we do on the personal level. And you do not, want to basically create a situation in which you're putting your personal stuff out there in a way that jeopardizes your children, your family members, and et cetera, simply because they had a new birthday and you want the whole world to know about your birthday. Well, if you put it on the internet, wherever you put it, it's going to be found by your clients, and the idea, I think most of us are at this place where we understand that, but I just, it's one of those things where in our effort to, particularly with the millennials, to reach out and share and all that sort of thing, to keep in mind that professional, personal distance and make sure that we keep those things separate. I remember with my students, they would do these glamour poses and stick them on Facebook, and I'm going, okay, we have a few domestic client men who very well might be attracted to you, and you're setting yourself up, and you could prevent that very well by, not doing that. I think we spoke earlier about crisis intervention, and this is sort of related to that. It is the idea that if there's an alternative treatment, if the technology blinks, what's your backup? And making sure you work with the client in advance to say, if our sound goes out, what are we going to do? If the video goes out, what are we going to do? And it's pretty simple. You know, you go, let's move to the telephone, let's move to cell phone, the smartphone. But I think making sure that if the client's in this position where something's happening, I've been working with 2 groups on using Zoom right now. And in one case, the audio went out, and the other case, the video went out, and we had to figure out what we were going to do about it. You know, and in our case, for example, chat, you know, became the backup for one of the members that was there. So we have about 10 minutes left. Let's sort of take a look at what have I raised that you're going, can we go back and talk about that a little bit more?
Yeah, I wanted to point out that Dr. Tracy Oliver says that simple practice is great. I don't know, Dr. Oliver, if you can, and Carrie is also thumbs up on that. And so maybe one of you, we can tap one of you to do a little presentation on that sometime as to what you liked about that. So Dr. Oliver, Carrie, if you would turn on your mics, maybe you could say a couple of words about what about it did you like so well? How did it address some of the issues that Richard has brought up?
Simple practice. They have an integrated telehealth program, so you can do your appointments, schedule them online, and everything is double encrypted. You can even password protect it if you wanted to. The client could join the meeting before. It's very similar to how Zoom functions, but it meets the HIPAA regulations. I know with the Zoom accounts, if you wanted to meet HIPAA regulations, you have to pay an additional cost. So with Simple Practice, this is a $10 feature that you have to pay additionally to their services every month to include the video option. I found it very easy. It sends the link directly to the client. The client is able to join automatically. I don't have to, I use Zoom as well, but I don't have to worry about it as much, I feel, when I use it through the Simple Practice.
Great.
You can also create a private client portal where they can complete identifying information for you: name, address, telephone number,
insurance, emergency contact,
yes.
Everything you can think of. They have templates and forms. I think it's a great integrative option for.
I agree. They have a consent form as well for telehealth.
Yeah, they do.
They have some pre-made forms. You can add to it as well, but that they cover some stuff fairly well, and it's record keeping too. And I think, not to give it a huge plug, but I thought we got a little discount for it through AAMFT.
I don't know.
So
they did. They offered 2 months.
We did, yeah.
At one point, and for all AAMFT members to do a trial. And I don't know if that option is still available, but it was available earlier. And I think it's a good option. And adding to the forms, you can create your own forms, and it might not seem like a big deal, but when you are editing forms or you have your own forms that you would like to use, it has them on there. They have a lot of the, common diagnostic assessment options on forms as well. So it's a great option.
Yeah, it sounds like that you could, if you wanted to upload maybe the APA cross-cutting to do diagnostic work, or if you wanted to upload a Beck inventory or those kinds of things, it sounds like it has that kind of flexibility. And Carrie and Tracy, it sounds like it addresses an awful lot of what Richard mentioned. Is there anything it didn't address that Richard mentioned?
Not that I can think of.
Not you can think of,
Yeah,
okay.
I can't think of anything either.
But I would say to you, when we're talking about future webinars or future discussions, this idea of electronic record keeping would really be a very rich topic for us to explore. you know, what are the pros and cons of each? What's the pricing of each? What have you discovered happening or not happening with each? And how, you know, how are they used? And you know, those people who are into private practices, it looks sort of one way, but then these group practices can also use them. Community mental health agencies can use them, and what are the pros and cons of using them in each of those settings? I think they would really be an excellent topic for us to explore.
Definitely. That's fun.
Tom, you have not indicated a question of interest. Is there anything in what we've talked about that you'd like more information on or comment on? Was this worthwhile for you? Or just give us some kind of sense of what's been going on for you. If you could do that, and maybe you need to chat, I'm not quite sure. I noticed you popped up under chat, but I haven't heard from you. So just wanted to give you an opportunity to say anything if you'd like to.
Yeah, it'd be great. And as well to Andrea and to Meredith, Tom says he doesn't have anything yet. He's just very interested in the topic. So very good.
Good.
So just it'd be kind of fun to take a quick little poll here.
Absolutely.
Carrie and Tracy, obviously you both are doing distance therapy via video and such like that. I know I am. Richard, I know you are. Meredith, could you chat in and tell us if you're doing any of that work now? Irma, how about you? Are you doing any of this kind of distance therapy, or are you mostly staying just to our meetings?
I am very traditional.
All right, come on.
This, what I'm doing right now, is a big stretch for me.
It's a big stretch for you. Well, and good for you. Good for you, Irma. Yes. So in addition to therapy, I also do tons of supervision in this kind of environment, and teaching. Lots and lots of supervision and teaching in this environment.
Yeah.
So that I think that it's here to stay, so we better learn about it. And the other thing I was thinking, Richard, is when we were talking about 15 hours of training, which at the face of it seemed like a bit much, but I could see us putting together a workshop where there was a real maybe assessment of each participant's use of Twitter and Facebook and all that, and actually kind of assess, you know, where you're doing it right and where you might be doing something risky. Because I would say that this environment's pretty straightforward, but those environments, there's so much going on behind the scenes that you may not know is going on. I could see warranting getting all of that in 15 hours of training.
Yeah.
So.
The other thing that I wanted to talk about, and I guess we talked about it earlier in this session, this idea of what's happening with students and what are they getting credit for? Are they getting credit for telemental health or not, or being denied? I would really encourage some advocacy, you know, and whether it's student leaders putting petitions together and, you know, 25 of them send a petition to the board that says, we want our telemental health hours to count, or
well, so just in case people don't know what we're talking about, at the present time, for both pre-masters and post-masters, in most contexts I'm aware of, and maybe some of you will know other contexts, the students and registered interns cannot count telemental health as direct contact hours. Or if, say, they're in a substance abuse treatment area, the inpatient person is with them and they're involving the family via telemental health, that doesn't get counted as relational hours, which for mental health and social workers, that's okay. But for MFTs, that could be a huge burden to trying to get licensed or their hours. So yeah, I agree, Richard, we need to advocate for that big time.
If you didn't notice it, Carrie put in the chat that the Florida Certification Board, I'm not familiar with that group. She says that they have a e-therapy certification that covers a lot of the stuff that we've talked about today. Carrie, we've got a couple minutes. Could you inform us a little bit about what you know about this group?
Sure. It's the Florida Certification Board is the board that grants when, for people that perhaps are working in substance abuse and they want to get their CAP. So that's who you go through. Okay. So I did take their e-therapy certification 2 years ago. It wasn't bad. Certainly wasn't 15 hours worth of material. Dr. Donnelly Snipes is the one that basically pulled together their material, but it was informative, and it covered everything that you kind of discussed today about, informed consent, making sure that you get lots of identification. What about suicidal clients? Would you work with them? Yeah. So I don't know, as things are being considered, or if we pull something together that would apply more to our scope of work, if we'd want to take a look at what's already out, don't reinvent the wheel, obviously. Right. Take a look at what's out there and see. It costs me $75 a year to keep that certification up, and I don't have to redo anything. It's not, it's a little.
That's a bit of a racket. Thank you very much.
Yeah.
You're not, what the hell are you getting for your $75?
This little number that says E, and then I got all these little numbers. And
right. And of course, nobody requires that right now. Nobody, the state doesn't require it. Nobody requires it, but you're a good person to do that.
I thought I was having just some forethought of, well, maybe I should consider doing this. This is the way things are going. Who knows what's going to happen? So, sure. But it might be, just to put out there, might be something for us to look at in pulling together material.
Sure.
Thank you very much. Appreciate it.
I think desperately we would need to broaden it to, how do we do this systemically? How do we do this with more than one person, either in the house or wherever they are, or multiple boxes of family, thumbnails of family members? Definitely, I think we need to, we could expand into that. Sorry, Richard.
And to include what Richard had said about the electronic health record training.
Yeah.
And fold those together. I wanted to check, Annalyn, if I have a PowerPoint, how can I get that to participants today, or can you do that? Or?
What we can do is we can put it up on our web. Andrea, I know you're listening right now. So Richard, if you will send it to me, I'll make sure it gets into Andrea's hands, and we will post it on our website. And as soon as AAMFT gives us the link for the recording, we will also post that on the website, so you can listen to this again, or you can tell other people to come listen to it. I think Richard, you have done in an hour what these other places want to do in 15 hours, but at least to highlight those things. And if we ever did an expanded one, whatever the state requires, we might then actually create forms and things that would make it worth having a longer time.
Yeah. Okay. Well, good. Okay. So thank you very much. What we've done is taken a look at some ethical issues, taking a look at training options, broach the issue of clinical issues and what we might consider, and close with a lively discussion of best practices. Thank you very much for joining me. We'll get you the PowerPoint and provide you with the access. And I've enjoyed our hour together. Thank you.
And if any of you want actual C credit for this, will you please email me? I've just put it in chat. It's annalyn@nova.edu. Could you please email to me your I have your full names, but if you would also send me your license number, and what I'll do is I'll send that off to AAMFT, and they will send you back the CE certificate that you will then upload to CE Broker. All right? All right. Thank you much, everyone. And we'll see you at the next event in September.
Great. Thank you.
Good night.
Bye.
Bye.